breathing day and night disorders, because really it's come to, in my experience, that that's the prevalence and the origin of many of the chronic things that we've been treating for many years. In the courses I teach, we talk about neuroanatomy and how that affects every essential function of the human body. So understanding that and its correlation to occlusion and function is extremely important. I always start with the understanding of the central nervous system, and understanding that the difference between the somatic and the autonomic nervous systems. So basically in the brain stem, or excuse me, in the cerebrum, this is actually the somatosensory cortex. So this is the part that is unconscious control. So this is you thinking about doing something and then doing those things. But then that has to be mirrored with the autonomic regulation, and that's from the midbrain. So these structures automatically get your organs going, keep your heart rate, digestion, all the automatic functions, muscle tonus, to keep you upright and to move you with not under your conscious control. So if you look at your peripheral nervous system, you'd find that 30% is somatic, that can be evaluated with conduction tests and things like that. But 70% of it is autonomic, and that rarely gets evaluated. And there's where a lot of the connections and pathologies reside. So we understand the mechanism of how a noxious stimulus makes its way from the head down the neck and all the way down sometimes to cervical, vertebrae 4, and where it crosses over and ascends up to the thalamus and then out to the somatosensory cortex, where it's interpreted as pain. So we understand these mechanisms. What becomes difficult is that the cervical spine at those levels also dumps into the trigeminal spinal tract nucleus with the diagram that's on top. And this is showing you that the source of pain may be a cervical problem, but because all three branches of the trigeminal nerve are also merging with this cervical injury at the subnucleus caudalis. Now there's a receptor site there called the N-methyl D-aspartate receptor. So this inflammation pulls magnesium out of that receptor, allowing more pain to ascend out to the thalamus, as shown you in the red line here. And so what becomes difficult is that as pain now goes to the thalamus and synapses, third order neuron out here in the somatosensory cortex, that now there's a descending change to the nervous system. This is the diagram right below it that shows now that you have a different pathway that now is causing inflammation in the mandibular branch of the trigeminal nerve that innervates the jaw. So this patient's going to come in talking about their jaw hurting them, as opposed to when the origin is the neck. And in the upper, that would be a person who's coming in with neck pain, but maybe they're clenching, and so their jaw hurts. So the question is, how do you separate these people? Because they need different kinds of treatment. In fact, if you treat them the same, you'll have different results. So we understand that pain is very disturbing to sleep. Acute pain will have certainly fatigue, because of interrupted sleep, but it doesn't really change the nervous system. Chronic pain, on the other hand, produces insomnia. 50% of all insomnia is related to pain. Continued disruption of sleep produces mood disorders. In fact, psychosocial problems, anxiety, depression, and increased pain in the daytime. So the less sleep you have at night, the more pain you're likely to have in the day. And so this revolving mechanism is basically how we see our patients come in, because this thought process of understanding that grinding your teeth is a medical problem. Sleep bruxism is a movement disorder categorized with restless leg and periodic limb movements. And so this is a central nervous system problem. Something is disturbing sleep that then is causing this muscle movement oral manifestation. So the thought process that if a patient came into us and said, Steve, can you help me with, I'm grinding my teeth. The last solution that we would give them is to grind their teeth. I mean, I'd feel silly telling them, oh yes, I'm certain I can fix your problem. I'll just grind the teeth better than you can. That's not exactly a medical response. So understanding that the American Academy of Sleep Medicine categorizes sleep bruxism right there with leg cramps, movement disorders, restless leg, periodic limb. And so we understand that there's actually some stimulus. And that stimulus could be trying to breathe. That stimulus could be obstruction through the nose, in the throat. It could be pain. It could be all a combination of things. They have to be dissected and separated in a triage way, because the symptoms of these problems are evident to us. This is what dentists are treating every day. They have fraction lesions, the fractures in the teeth. And so simply, if you have patients who have cracked teeth, you certainly should fix those, but you should investigate this mechanism, because there's likely a very high comorbidity with the sleep breathing disorder. Certainly weight is a huge factor, but if we look at the two greatest factors of treating people for sleep breathing disorders, we see that BMI, body mass index, and nasal obstruction are the two greatest hurdles in helping people. So men with a 17-inch neck or greater, women 16 inches have a high risk for sleep breathing disorders. Anyone who's obese, a BMI of 30 or greater, has a very high risk. But I ask you not to discriminate by weight. I ask you to look at symptoms, awakening from sleep, grinding of the teeth, and things that are more obvious, like scalping of the tongue, which is 70% predictive of obstructive sleep apnea in the otolaryngology literature. So we'll see that this tongue is what's pushing teeth out of bone, and that's why you see receding gum lines and these kinds of perio conditions, because it's a maintenance of an airway. And so this is what you'll also see with people grinding their teeth. Our solutions to this are to make night guards, this thought process. But what most people don't understand is that if you put a night guard in a patient who has obstructive sleep apnea, you're likely to make the apnea 50% worse in 40% of the cases. So, and the reason is that many of these things are mechanical, positional. Night guard doesn't hold a position, so the jaw can still slide back. And of course, you have the physical presence of the device, which is crowding the tongue and forcing it further back down the throat. So we need to be thoughtful about what it is that we're treating, because the thought process, we can't hurt anybody, is not true. If we look at dentistry's role in sleep medicine, this was published in Sleep Medicine Clinics. It's a physician newsletter that comes out quarterly. This was March 2010. We can see that the clinical findings that indicate a risk for sleep breathing disorders are coated tongue, that means mouth breathing, enlarged tongue, scalping the lateral borders, as I just reviewed, and a tongue that obstructs the view of the oropharynx. So if you can't see an air hole when a patient opens their mouth, the likelihood of they having a breathing problem is great. Teeth and periodontal structures. So if a patient has gingival inflammation, gingival bleeding when probed, dry mouth, gingival recession, tooth wear, or abstraction lesions, these are all patients who should be evaluated for sleep breathing. I think that's the predominance of what we do in dentistry. And I actually think dentistry has a lot of local therapies for systemic problems. And I think this is evidence of that. We should also look at the bottom there. We should look at posture of the head and neck. Now, this is something new to dentists, that we should look for forward head posture, loss of lordotic curve, posterior head rotation. So these are all things that happen to people who have breathing disorders. They're always leaning forward. It's very dramatic in some cases. So neurology is the key, because that's the mechanism that stimulates muscles to move. And those are the issues and the microtraumas that produce the orthopedic problems that patients deal with. And so it's important for us to appreciate the fact that these mechanisms are stimulated by function. And if there's aberrant function because of obstruction in certain cases, especially of the breathing, and breathing can be obstructed not just at nighttime, in the unconscious state. I think we have to separate those things. We have to separate the unconscious collapse of the airway from the functional breathing problems or absence of nasal breathing. The nose is the organ for breathing. It just seems odd to me that the most vital function of a person, which is breathing, is the least evaluated by a medical professional. And so we start to look at speech and we see, well, how does the tongue function in these mechanisms? And so this is a German explanation of a new technique called MRT, but if we just look at the mechanisms of speech,
sondern eine Aufnahme mit der Magnetresonanztomographie oder kurz MRT, die auch als Kernspintomographie bekannt ist. Das in Göttingen neu entwickelte Verfahren der Echtzeit-MRT kann beliebige Bewegungsvorgänge im Körperinneren mit einer sehr hohen zeitlichen Auflösung aufnehmen. Da gleichzeitig auch der Ton aufgezeichnet wird, verdient die Wiedergabe der Sprache besonderes Interesse. Das Geräusch der MRT-Messung wird dafür weitestgehend unterdrückt. Dieser MRT-Tonfilm wurde mit 55 Bildern pro Sekunde gemessen. Man erkennt dabei Form- und Lageveränderungen des Zungenrückens, des Zungengrundes, des weichen Gaumens, des Kehldeckels und des Kehlkopfes. Achten Sie bitte auf diese Vorgänge bei den Vokalen A, E, I, O, U sowie bei den Konsonanten L, M, N, R, S, T.
S. So I captured S so that you can see how the tongue is down to the lingual surface of the lower anterior teeth. In this position, it's been demonstrated that denture retention is increased by almost 58%, so using phonetic techniques. And so this lends itself to understanding, well, why do adult humans have apnea? And that was outlined in this paper. Terrence Davidson, who's a a professor of ENT here at the University of California, San Diego. And he wrote this article, The Great Leap Forward, the Anatomic Basis for Acquisition of Speech and Obstructive Sleep Apnea. And he's talking about the fact that all other mammals have this palatal lockup. So the primates, and the gorillas and the dogs and infant adults all have the epiglottis and the soft palate in contact. So they can breathe and eat simultaneously. But somewhere around 18 months, we have a descending epiglottis, ascending soft palate. And this creates a muscular tube that can collapse in the unconscious state. So it makes sense that if the reason why we suffocate at night is because of speech, then it always made sense to me that phonetic techniques or physiologic techniques would give tonus to an airway and restore its function. So I published this paper back in 2007, use of phenom registration protocol to prevent upper airway collapse. See, people with apnea, they have airways that are just fine during the day. I have apnea. I wore my appliance last night to keep my airway open. But, so I have collapse of the airway when I'm unconscious, but I have no problem speaking to you right now. So in this paper, what we did is we used kind of a sonar device called pharyngometry to be able to discern the dimensions. And we found that using a phonetic technique, we increased volume by 12%. We decreased the collapse of the airway from 25% down to 16. So we had greater patency and less collapsibility using this technique. But also, it also blocks neurotransmission, because if you've got a painful jaw that may be inflamed because of these common, you'll get some very amazing things. Now, here's a gentleman who woke up from anesthesia from surgery, and he had what appeared to be stroke-like symptoms. This is from our center in Texas.
My name is Richard Stats, and I am 50 years old, and I am married. I have 3 children. I I've lived here in Louisville for 15 years, and I was born in Houston, Texas, and I had lived in Kansas. And
So here he
my name
is
Richard Stats.
with a bite registration in his
I
mouth.
live in Louisville, Texas.
30 seconds later.
And I'm married to my wife, and I have 3 children. You want me to keep continuing?
So you can see that understanding what happened to him was that he was intubated and they injured his jaw, and he woke up like that thinking he had a stroke, and they were doing all sorts of tests, and no, it wasn't that at all. It was simply aberrant speech from inflammatory problems of the jaw that caused those neural injuries. But and so understanding those mechanisms, you can have an effect, but also understanding that nasal obstructions can produce aberrant speech and therefore aberrant bite relationships. Look at this gentleman here.
60, 61, 62, 63, 64, 65, 66, 67, 68, 69, 70. Open and close. Open.
So you can see orthopedically, there's nothing wrong there. However, when in speech, you saw his jaw deviate over to the left. Okay, well, now here he is with simple nasal dilation, some nasal spray.
60, 61, 62, 63, 64, 65, 66, 67, 68, 69, 70. Open and close.
So that's not just in South Bend, Indiana. It's also all over the world. We see this. This is our center in Bahrain.
65, 66, 60, 67, 68, 69, 70, 61, 62, 63, 64, 65.
So the nasal sprays that we want to use have to be sprays that do not produce rebound. One of the products that I found is hyperosmotic saline with xylitol for its antimicrobial properties. And I authored this paper that was published just a few months ago where we demonstrated that we got a 20% increase without that rebound effect. And so it's not just dilating the nose, it's spraying the nose to make sure that it's patent all the way through with patients that have soft tissue hypertrophy. And so we start to look at, well, what's the prevalence of these breathing disorders, of obstructive disorders? Because years ago, we thought there were only a few percentages, but now we're starting to see greater and greater numbers. In this paper here, the prevalence increased in time, and OSA was reported in 37% of men and 50% of women in studies from 2008 to 2013. In the more recent studies, like we see in the Journal of Dental Sleep Medicine, we see up to 50% of men and 23% of women aged 40 to 85 have moderate to severe OSA. And so that means that they stop breathing more than 15 times an hour. The estimated prevalence of OSA has increased by 14 to 55% over the past 2 decades. And most individuals have OSA as undiagnosed and untreated or undertreated. And that's certainly the case. So I was wondering what the numbers might look like in South Africa. And apparently there's a prevalence rates that is a AHI greater than 10. So that would be, the mild to the reaching up to the moderate ranges between the ages of 20 to 44, 45 to 64, and 65 and above. So we're seeing a 3.2% to 11%, 11.3, and 18.1% respectively. Amongst women, there's an increase in prevalence. So there's increasing prevalence in your area as there is everywhere else in the world. And now we're starting to see that we need to triage in different ways. Christian Guilleminault, the seminal figure who developed the AHI process, which he did not support and did not agree with, and we're so sorry that we lost him a few months ago, a huge loss to humanity. But there has to be other ways other than just AHI to look at. And so one of the things that we're looking at is the PCRIT. That's the amount of displacement pressure that it takes to collapse an airway. And so looking at 2 centimeters of water displacement might be a defining role. We also look at poor muscle recruitment. Muscles, as we get older, we lose tonus, so they collapse greater. So that's why apnea gets worse as we get older. There's a neurologic component. How do we react when we don't breathe? That's called loop gain or high loop gain. When you have an exaggerated response and you have, and you're hyperventilating after you cessate breathing. Or there's low arousal. You just don't wake up, or you're not responsive to the carotid plexus sympathetic nervous system. That as your CO2 is rising, that would be normal for most people, but in some people they don't respond to that, and as a result they have long hypotonias. So our treatments are a bit different now. We're looking at muscle function, exercises, medications, positive pressure, oral appliances, positional therapy. All of these things are taken into account, and we need to evaluate. So understanding how to interpret a sleep study, whether it be a type 1, which is an attended study with 16 channels, or a type 2, which is essentially the same thing, it's just not attended, or type 3, which is basically a take-home version that can give you enough information to make a diagnosis, all the way down to type 4, which is basically pulse oximetry. This would be an example of a type 1 hookup. And that's the kind of thing we were doing in our office in Dubai. So this is our TMJ and Sleep Therapy Center. I used to fly to Dubai once a month to treat patients there for a few years. And in that facility, we had a relationship with a sleep physician where they would, so he would come in and he would diagnose the patients, the ones with obstructive sleep apnea, then he would turn those over to me for evaluation using CBCT. And so then I would triage. I would figure out which of these patients need to be sent downstairs to Dr. Mueller, our ENT from Germany, who was there. A sleep physician that I worked with was from the UK. And so a real international team there. So some of them needed surgery, some of them needed positive pressure, some of them needed oral appliances, or a combination with positive pressure and oral appliance. And so we were able to treat them, and the ones that, of course, that had chronic pain, which has a high comorbidity, were all treated in this way, and it made things very easy to do. I think it's important for people to understand pharmacology that for craniofacial, orofacial pain, as it affects sleep, because all of the drugs that are used for these conditions are centrally acting, which means they shorten sleep, they lighten sleep, and they decrease REM. And these are significant problems. A few slides from Dr. Deepak Srivastava, who's a professor of pulmonology at UC Davis, shows us that benzodiazepines and barbiturates significantly decrease N3 or quality sleep. They increase lighter sleep, N2, and they decrease REM. And this is difficult for the patients who have memory issues and this sort of thing. Total sleep time certainly goes up, but it's medicated sleep and not quality sleep, and that only worsens their depressive component. And that's what we see with these selective serotonin reuptake inhibitors that are used for depression. They all worsen sleep. So the drugs that we give people for bad sleep worsen their sleep, and that's really the issue. We need to look at sustainable diets for the world and more plant-based. Sugar, we understand, is particularly damaging and toxic to the body. If we look at articles, this is our California Dental Association talking about patients who are made worse with different kinds of sensitivities. In this case, dairy. Traditionally, in our practice, we use deflaming anti-inflammatory diets. We recommend patients not have dairy, not have wheat nor sugar. We try to take them off all of these things. In our country, North America, we've got GMO wheat and corn, so this is highly inflammatory stuff. And so we see a lot of lichen planus and this sort of thing. In this case, is just showing there was resolution of this problem simply by taking them off dairy. I treated this patient here because the person was referred over by the sleep physician for apnea, and I successfully treated that with oral appliances. But the patient was on 4 different medications for insomnia, and so it was he just, even with the medications, he still couldn't get to sleep, and he had terrible fatigue in the morning. So just by getting him off of dairy, we were able to get him off all of those medications. So here's her response: multifaceted, excellent clinical response to oral appliance therapy for the treatment of mild to moderate obstructive sleep apnea. Eliminating dairy has also been a benefit as the insomnia has resolved. So who would think that what you eat and when you eat it makes a difference in how you sleep? But it's a fact. So diets that are low in fiber, high in saturated fat, high in sugar are going to produce more sleep arousals. And in fact, sleep arousals is the reason for cardiovascular disease. It is the cortisol producing oxidative stress that's issues. And just recently, just a few months ago in our California Dental Association, we start looking at probiotics in the treatment of peri-implant diseases and looking at a systematic review of literature showing that different formulations of probiotics are necessary to restore function. And so that's basically what we see with a lot of these patients. We see they have leaky gut, and especially your migrainous patients. So there's a digestive problem. You have a cell barrier in your digestive tract, just like you have a blood-brain barrier in your brain to prevent entry of large molecules. Well, in the case of this leaky gut, then you have inflammatory processes, even blood cells that can pass easily through these openings that cause systemic inflammation. And so that's why probiotics are now effective in restoring function, and that's a part of our mechanism. If you look at the literature, even the orthodontic literature demonstrates the benefits of probiotics in patients with orthodontic therapy that are having infectious issues with strep mutans and lactobacillus levels. So understanding the pathophysiology of sleep disorders, these are a few slides from Dr. Selecki, who teaches at University of California, Los Angeles. And he's allowed me to use a few of these slides just to share with you the fact that if you look at obstructive sleep apnea and sequela, so yes, the oxygen desatting and the hypercapnia increases in CO2. But if you look at the bottom there, it's really the arousals that produce the sympathetic activation that stimulates heart rate function and produces vascular oxidative stress. So the cortisol that you produce from waking up causes a systemic inflammation that increases coagulation. Now you produce metabolic dysregulation, leptin resistance. Leptin is a hormone you produce from your fat cells that tells you you're satiated. So when you're interrupted from sleep, you're constantly producing it, so you downregulate, kind of like you do with type 2 diabetes. And so then you just don't respond to it. So now you're hungry all the time. So you wake up hungry. And so what do you wake up for? You wake up hungry for carbohydrates. And this just increases insulin levels. And of course, the more you're interrupted in sleep, the more you have high sugar levels, high insulin. So this all leads to cardiovascular disease. And so congestive heart failure, cardiac arrhythmia, and atrial fibrillation. That's one of the first symptoms we see. So if you have a patient with increasing apnea, this is showing that if a patient is a moderate apneic, has AHI greater than 15, they're almost 3 times more likely to have hypertension. And that's a factor when we look at health histories. We see if a patient's on more than one antihypertensive med, the likelihood of them having a sleep disorder is great. Atrial fib is one of the first signs that we see in patients with these kinds of breathing disorders. So we have a high prevalence throughout the US for atrial fib is just going through the roof with these abnormal beats. And we're seeing increasing numbers. And certainly as people get older, we're seeing a greater risk. And so the risk factors for that, advancing age, high blood pressure, obesity, European ancestry, diabetes, heart failure, ischemic heart disease, hyperthyroidism, chronic kidney disease, heavy alcohol use, but nowhere there do we see that they talk about sleep breathing. And but if you have atrial fib, that increases a person's risk for stroke by 4 to 5 times compared with stroke risk for people that don't have AFib. So I looked up what the frequency might be in your area, and I saw this paper here that says that atrial fib is on the rise in South Africa. So healthcare in sub-Saharan Africa is being challenged by a double burden of disease and lifestyle, and it says that the risk of stroke and atrial fib, which is moderate to high in Africans as in the developed world, continues to the high mortality, contribute to the high mortality rate. And so you're seeing an increase in your area just like we are. Now, if you look at the literature on the comorbidity between sleep apnea and atrial fib, we're starting to see that cardiologists like Dr. Wharton here is recommending that all patients who are being treated by a cardiologist be screened for AHI, for sleep apnea. He says the study concludes that a wide screening should be done in at-risk population. Wharton says the cardiologist's office is the natural place to look for sleep apnea. The patient population is not really selected for you. And he says that for patients who do navigate the clinical pathways, he says AFib and sleep apnea should be treated in parallel. He says it's nice when you can find a potentially reversible cause of AFib, but obviously you have to treat it until you are confident that it is no longer there. You don't want them to be a stroke risk. However, he says, wouldn't it be a lot easier instead to treat the sleep apnea, give them anticoagulants, and place them on a diet when BMI is a factor? So understanding the risks and looking at health histories can give you a lot of information about how sick people are. Now, the link between perio and OSA, we've understood the link between perio and cardiovascular disease, but the precursor to cardiovascular disease is often a sleep-related breathing problem. And so we see mounting literature on the comorbidities. So understand if you're treating a patient for perio, you should really be taking a look and investigating their sleep pathology. Some simple questions to ask are, can you get to sleep? Can you stay asleep? In other words, do you have primary insomnia? Do you have secondary insomnia? Or do you wake rested? Because you might be able to get to sleep, stay asleep, but the quality of your sleep is so poor that you wake fatigued. And that is a high marker for understanding there's a sleep pathology. So it really comes down to some molecules. I'll let this video describe that.
Nitric oxide is naturally made in our bodies. A Nobel Prize was awarded for the discovery that nitric oxide plays a significant role in the cardiovascular system. This discovery revealed nitric oxide as a vasodilator, helping to reduce blood pressure and increase oxygen in the blood. Produced by the lining of the blood vessels, known as the endothelium, nitric oxide acts as a messenger molecule, telling blood vessels to widen or dilate, and contract or relax, like an elastic band. With enough nitric oxide, blood vessels can relax and widen, allowing blood to flow from and to the heart. As we age, we produce less nitric oxide. This can cause the cardiovascular system to become less elastic, which can reduce the flow of oxygenated blood to vital organs. This is the reason it's important to have an active lifestyle and a diet that's rich in nitrates, which bioconvert to nitric oxide and may help maintain normal blood pressure levels and a healthy cardiovascular system.
So in fact, we can use nitric oxide as a marker for cardiovascular health. And that's what this paper is talking about. It was published in Sleep and Breathing a couple of years ago, and measuring exhaled nitric oxide. So sleeping less or more than 7 hours is associated with pulmonary endothelial dysfunction as measured by ferric nitric oxide. And so understanding that 5 hours or less or greater than 10 hours of sleep, it greatly increases cardiovascular risk. And understanding the quality of sleep and how that affects us. Nitric oxide is concentrated in your sinuses, so your frontal, your maxillary, sphenoidal, and ethmoid sinuses, and every nasal breath brings that gas into your lungs. Besides the fact of causing peripheral vasodilation or lowering your blood pressure, it also is antimicrobial, so it kills virus, bacteria, and fungus. So every nasal breath is your immune protection against respiratory problems. And so if you don't breathe through your nose and breathe through your mouth, then you have a greater risk of high blood pressure and, of course, pulmonary problems. So we see this in patients who have obstructive sleep apnea, that they are at greater risk for osteoarthritis. So because of this systemic inflammation, that could be a factor if you're implanting. So patients who have total joint arthroplasty, so knees, hips, shoulders, this sort of thing, are at greater risk of failure if they have obstructive sleep apnea. And so that should carry over to our dental implants. And we should understand the failure rate is going to be greater in those people. And a lot of time that manifests as a bruxing problem. So the Journal of Oral Implantology published this paper talking about the facts that you're more likely to lose an implant if a patient has a sleep breathing disorder. The highest AHI and thus the severity of OSA was identified in patients with a fracture complication related to an implant, a screw, or a porcelain. The frequency of prosthetic complications has been higher in patients with obstructive sleep apnea. So if you're having issues, just understand that you may need to investigate the breathing problem. And certainly as we age, we know that, that apnea goes up. But one of the big factors that changes things is losing teeth. Because when you go from dentulous to edentulous, you double your breathing disorder. So I was told when I was in dental school that patients should take their dentures out at night because that increases the wear to the ridges and therefore instability. However, what we didn't know back then is these people might be suffocating, and now we're doing it at a greater risk to them. So we have to rethink. So whether they take them out or we take them out, we should be understanding of those variables. So when people come to me with chronic pain, and that's what I treat predominantly along with sleep issues, my job is to get their heads up because they come in these forward head postures in functional adaptation because of inflammation of the jaw that causes forward head posture, and basal obstruction causes subluxation. As a result, you see changes to dentition, you'll see all sorts of facial problems. And for me, the predominance of what I see is that what we're really treating is breathing disorders, and the muscular and joint problems is really simply the symptom of the problem, not the problem itself. And that's why more and more invasive therapies for those don't seem to work very well. So understanding that every time you move your head, you move your entirety of your spine all the way to the sacral tip, the coccyx, and also your hips. So slight head rotations change everything about you. But who would guess that a breathing disorder at night could affect your posture in the daytime? But that's what we see. If we look at the literature here, the orthodontic literature, and this was published a few years ago, about the relationship between head posture and the severity of obstructive sleep apnea. So they took these measurements, these cervical measurements, and they showed that in group 1, where these were controls, people without apnea, group 2 had mild apnea, group 3 had moderate apnea, group 4 had severe apnea. You can see the top line there that shows that there's an increasing angle here of forward head posture, the greater the apnea. So understanding that mechanism and certainly understanding that occlusion is going to change in body position, then we have to factor that in as dentists to understand that maybe what we're chasing occlusion is really a functional problem of the whole body, not just the mouth and the head. If we understand how the mouth moves, then we'll understand that it has to lever against your cervical spine in order to make these motions. And so head posture can severely change that relationship. So in general, the more severe the OSA, the more extended these head postures are. So how does that factor into people who may also have chronic pain issues? Well, this was a poster study at the last year's Academy of Dental Sleep Medicine meeting. Impaired control of gait in patients with severe obstructive sleep apnea is reversed by continuous positive airway pressure treatment. So not being able to walk can be fixed by treating the apnea. Well, here's an example from our center, Dr. Charles Fursley in North Carolina. So here's a woman who she can't walk and has to be carried around by her husband, and he's demonstrating.
Now, let's walk forward.
You can see how difficult that is for her, how much concentration it takes. And thank goodness there's a wall there, otherwise she would fall over. Now, who would guess that simple decompression of the jaw can right that problem? Because it isn't just the jaw. The whole spine is changing its relationship because it was adaptive because of the inflammation of that jaw. Even swallowing is enough to produce these kinds of problems, because when you swallow, your teeth come together, and that's the farthest the condyle goes into the socket and irritates that inflammation. So now you can see she can walk forward and she can walk backward without assistance. So understanding these parameters greatly allows you to help patients dentally as well as medically. So where does this all begin? Well, I'll tell you, it all begins with mom. So because all the people who had stroke, have OSA, have had it since they were a fetus and likely got that from their parents. So sleep disordered breathing seems to occur with a prevalence of 15% in healthy obese pregnant women and 50% of high-risk pregnancies. So every other high-risk pregnancy has a sleep breathing disorder relationship. And a few years ago, I had the pleasure of hosting Dr. Guilleminault at our American Academy of Craniofacial meeting. And Dr. Guilleminault, the seminal figure, a pediatric neurologist and sleep specialist who just did amazing work, was demonstrating in this presentation how we can measure the angle, the facial angle of the fetus to know whether or not the baby has apnea and how we deal with it. Kevin Boyd shows us these skulls from the 19th century and shows us how much we've changed to the 21st century in these retrognathic situations. And this is Guilleminault on stage talking about the impact of the condylar growth, and that the inferior facial angle, which is should be about 65 to 69 degrees. If it's less than that, then the person's likely to have apnea. And so now when they're born and we identify we have these problems, we try to use adult techniques on them, but they don't work. If you put CPAP on a child, you will magnify their apnea. I saw this when I was treating kids at the University of Tennessee, and we saw that these kids were getting worse. We saw them where they'd come to us at age 10 and have severe apnea, and we look in their chart and see that they start out with mild. And the reason is because this paper here, published in the Journal of Clinical Sleep Medicine, demonstrates that if you put CPAP on a kid, you arrest their development. In A, it's showing you the maxilla of a child with apnea that's had been treated with CPAP. And as you can see, there's really no change in the maxilla. So the whole rest of the head's growing, but not the maxilla. So it's magnifying the midface deficiency. Whereas in B, those kids had apnea, but untreated, and you can see the maxilla growing down and forward as it should. The only problem is these kids are suffering from the breathing disorders problems. So anyway, understand that's the mechanism. I published a paper a couple years ago with one of the children that I treated at the University of Tennessee. And so this young girl stopped breathing 118 times an hour, and we got her down to 3 in just 8 weeks by doing orthopedic techniques, even though she was obese, even though she had osteoarthritis. She was on pain meds. She's hypertensive, a 10-year-old taking antihypertensive meds. So, this was a very sick kid that we were able to show that you don't have to do surgery on these kids to be able to affect that. And that'll tell you.
And really it affected anybody's life. She was on CPAP at a young age, and she was going through a lot of issues and things like that with her mate. And basically what happened when he came in, he started moving her jobs around, maneuvering some things around. She quit having sleep apnea, and they cured it 100%. It's amazing. We love it.
So your patients come to you with all sorts of aches and pains, and you have to triage this. So what we do is we go through a comprehensive evaluation, looking at range of motion, palpation, and we look at a number of things. CBCT is a huge part of that. I use imaging science products, ICATs, because they're the most durable and effective units that I've been exposed to, and I've been all over the world. And these units give us a lot of information so that we can then take all of the clinical data plus the subjective and put that together with a diagnosis that's based on philosophy and education, because what you're aware of so certainly change your opinion. And of course, the team approach that's necessary to treat these people, once you identify that a lot of the problems that they have are not dental origin, but may have, so it's really a new level of dentistry. And that was outlined in this article in the California Dental Association a couple years ago, where they talk about the fact that the American Dental Association recently proposed a definition of oral health as a functional, structural, aesthetic, physiologic, and psychosocial state of well-being. And they ask the question, is oral health is multifaceted, includes the ability to speak, smile, smell, taste, touch, chew, swallow, and convey a range of emotions through facial expression with confidence and without pain, discomfort, and disease of the craniofacial complex. So, are dentists really responsible for total well-being? This seems to suggest the need for more training and collaboration with other professionals. Well, that's exactly what I'm speaking to. At least, it says at the least, involving dentists in a functional, structural, aesthetic, and physiologic, and psychological, psychosocial states, a patient will require collaborative working relationships with a very large number of sister professionals. And certainly that is the case. And that's what we need to do. So the system I use is very different. My system is based on neurology and functional breathing versus the traditional orthopedic evaluation of the jaw and greater, more invasive therapies. The four things that I concentrate on are inflammation, are parafunctional activity, maintaining an airway, both day and night, and functional airway. That means making sure the nose works besides collapse of the throat at nighttime. And of course, nutrition, which is a huge factor. I use something called decompression appliance therapy for chronic pain. And this is chronic pain, not acute pain. And basically, it's a separation of either a positioned or non-positioned therapy based on a criteria of triage between symptoms of the jaw, which are I call TM primary, as opposed to jaw pain, which is secondary to something else, which we treat it, symptomatically. So there's always a way to help people, but understanding that there's no separation between pain, sleep, and crowded teeth, because crowded teeth is a result of an aberrant breathing, particularly nasal obstruction. So understanding those mechanisms and understanding the correction, we can treat these people in a routine way and have 95% of them not need dental therapy for these problems at the completion of 10 to 12 weeks, which is the time frame for our treatment. And we combine therapies, sometimes injection. Laser therapy has been tremendous in the ability to help these patients, especially the neural component. I wrote a paper with Matt Rago, the head of our orthotic laboratory, which produces all sorts of appliances for pain and breathing and orthodontic processes. We published this paper in the Journal of Orthodontic Practice, and we're basically talking about the evolution of appliances from acrylic to now printed, and which is really our specialty. And understanding that if you're going to treat the throat, you have to treat the nose. Something called the Starling resistor model determines amount of collapsibility. We're seeing that proper nasal surgery or proper opening of the nose through sprays and dilation decreases collapsibility of the airway by 46%. So managing the nose is very big. Now we've come out with printed appliances that allow titration, not just AP of the mandible, but also lifting the tongue up, which is what you're looking at there in the bottom of the page. And those blue areas, those are different ways to titrate vertically, to get the tongue forward, up out of the airway, and managing the nose as well. So using that technology and sometimes needing to combine it with positive pressure are techniques that work very well in your worst case scenarios where you have tiny little mouths, big tongues, maybe a big, heavy person, and oral appliance by itself wouldn't be sufficient. So we're basically able to help pretty much any situation, even orthodontic conditions. So you can't really separate these things, and I think it's so funny to listen to patients explain this to us.
Just go ahead. Okay. So I came in here with a jaw problem. I could hardly even open my mouth. What I didn't realize was that I also had a sleep problem. In fact, I kept saying, no, there's no problem. Well, I'm now using a CPAP machine, which helps me breathe at night, and I'm very well aware now that I had a problem. And I feel so much better now that it's being taken care of. I have more energy. I don't feel foggy in the morning. I'm not sleeping as long as I did, but I'm getting a better quality of sleep. So I'm kind of glad I had a problem where I couldn't open my mouth because I got a benefit, a secret benefit, and I didn't know it was going to happen.
Now, how many people would say that they had a benefit that they couldn't open their mouth? And it seems odd. But these are the things that people struggle with. And how come other practitioners don't know, as this woman will say? Oops, excuse me.
name is Mary Putnam, and I came to the TMJ Center because I had a change in my bite. My teeth, my upper teeth in the front didn't close down, so it made it really hard to eat certain foods. I was referred here by my orthodontist, and I wish more dentists and orthodontists knew about what they do at the TMJ Center. In coming here, I found out that I actually have a sleep breathing disorder, which I would have never guessed and I would have never found out about if I didn't come here. And so I'm very grateful for my treatment that I've gotten.
So this is our group of people in San Diego, and that might be a benefit just, to say, okay, these are the success and things we're doing. But that would be art. If we can teach this to other docs and they can get exactly the same kind of results, that's science. So if we can do reproducible steps and have the same patient could travel anywhere and have the same level of care, well, that's what we've established in our TMJ and sleep therapy centers. So these are all people that I've personally mentored. We are currently up to 63 as of this week, and we're dispersed throughout the world. So we have offices in throughout the US and in Canada, New Zealand, Australia. In the UK, we have 3 offices in the UK. We're in Dubai and Bahrain currently. And so we hope to take this all over the world because we want to establish a level of care where people have this kind of awareness of comorbidity. I'll give you a for instance. Here's this young girl, 17-year-old girl, comes to my office, and she's been treated for 7 years by the dental school just north of me and an orthodontics program there. And she's been a closed lock with an anterior open bite that they have not been able to change or do anything with for 7 years. And now they're telling mom, after invasive therapies into the jaw, that this 17-year-old needs to have total joint replacement, okay? And that's where mom started to look around and she found my office, and they drive hours down here just to for us to treat her. And so this is her open bite. This is her, that was her maximum opening. You can see the severe osteoarthritis in her left jaw, and that is severely melting away. And but the real problem with this young girl is nasal obstruction, soft tissue hypertrophy. You can see her nose is completely blocked. And 2 days later, we were able to get her up to 40 millimeters of opening and reducing her pain. And just recently she was she's up to 45 and no longer has to even use the day appliance anymore. So, and so we're getting her ready to be able to now have the treatment to close her open bite. So that's what I teach in the courses that I teach. I have manuals, and we take through a 3-session course and information. And that's the message that I've really tried to get out all over the world. I've had presentations at the University of Queensland and Griffith University in Australia. I've done this in the UK, Royal College of Physicians. I also presented the British Society of Study of Craniomandibular Disorders. We have offices in London, and presented to physician groups like the Royal Society of Medicine in London. I presented at RAC University, which is a medical and dental school, and lectured in front of the Minister of Health and to both physicians and dentists through the Middle East, and certainly through the U.S. At Midwestern School in Arizona, University of the Pacific up in California. I taught courses and helped the children there at the University of Tennessee. I've lectured at orthodontic programs at Harvard, and to try to get this word out and try to, we also, our centers are in collaboration with Boston University to ensure that this awareness and continued work towards pediatric OSA. There's so much, a lot of people are treating adult OSA now, but they're screening for children, but they don't really know how to treat children with OSA. And those are the protocols that we're working on. As a matter of fact, next weekend, we're having a symposium here in San Diego for our centers and invited the world experts to collaborate on those protocols. So we're working hard. I have the same message, which is basically my life from dentistry to medicine. And most recently had the pleasure of lecturing with my good friend Bill Martin, who teaches orthodontics there at University of Florida, doing the same thing. And so someday I hope to bring this education to South Africa. I'd love the opportunity, and perhaps next year I can join you for this fantastic meeting. I'm so proud and so thankful that I got the opportunity to share some things with you today. And I know you're tired. It's been a long day for you. You've listened to a lot of information. So I just want to say thank you for this opportunity. And I'm not sure how the forum works. I don't know if there's questions or if you guys are just tired and like to end your day, but I'm open to that. So let me just wait 1 second, and I will.
Can you see us, Steve? There we are. Steve,
Right here.
thank you very much for the time, your efforts, for the insight, for the information. We really appreciate it. And what I would like you to do, if you don't mind, is let's have 3 questions. Steve has got a busy day ahead of him. We've come to the end of ours. His is only starting now. So over to the audience, please, if anyone has any questions. No.
Wow.
Steve, I think they're stunned. And and what I think we do need is we do need to get you here next year. Thank you so much. And I do believe you have a birthday, your son's birthday this weekend. Please do have a wonderful weekend, and all our blessings from South Africa. And we really look forward to seeing you here. Thank you.
Really, very thank you. Let's see here.
Just getting the same thing.
Can't see. I have to go and get that. The innings end of it. Yeah, so I'll